السلام عليكم ورحمة الله وبركاته. حياكم الله جميعا. Welcome to our monthly activity in the Pediatric Cardiology and Congenital Heart Disease Society. We are pleased today to have Dr. Ali Alharbi with us. Dr. Ali Alharbi is a consultant of pediatric ICU and pediatric cardiac ICU. He is a creator of the rapid response team in our hospital. Dr. Ali have a huge experience in the pediatric cardiology cases, and he worked hard to improve the services in our centers. Today we face few cases in our life with pulmonary embolism, so we decide to ask Dr. Ali to invite him to speak about the pulmonary embolism in children. And we are thanks for Dr. Ali. He's accepting our invitations. And welcome, Dr. Ali, for this evening. And I hope we can enjoy your time with us. And you enjoy your time with us.
Assalamu alaikum wa barakatuh. Thank you so much, Dr. Umar, and thank you to have me on the group of the pediatric congenital heart, actually, and to give me the chance to raise the shine of the pulmonary embolism in pediatric, which seem to be increasing in incidence nowadays. And definitely your roles, guys, is definitely increasing on diagnosis as well as on therapy, especially on future circumstances on pediatric. I would like to share my slide if possible.
Okay, go ahead, Dr. Ali.
Bismillah ar-Rahman ar-Rahim. I would like to say, is the slide very clear?
Yes, very clear. Thank you, Dr. Ali.
Bismillah ar-Rahman ar-Rahim. So basically, I have no conflict of interest. Nowadays, I'm really the fans of the point-of-care ultrasound as well as fans of the invasive as well as non-invasive monitoring. So probably we'll hear about the point of care as well as the entitled CO2. So my objective to increase the awareness about previously low incident of the suspicion, which is we think on pediatric age group we would not see pulmonary embolism. You will be able to diagnose, suspect, and exclude pulmonary embolism. You will be able to triage based on the severities and to know ordinary support could harm more than making benefit of the patient with pulmonary embolism, and to know where and how to support kids with the pulmonary embolism. So we're going to go through the introduction, incidence, risk, pathophysiology, clinical presentation and diagnosis, and management, prevention, and future focus. So basically, pulmonary embolism, it is not a common occurrence in adulthood, but increasingly is rare event in pediatrics. It is underdiagnosed in pediatric setting because two reasons. First is actually patient on the age group is less compared to the adult. And the other thing is most of the manifestation, clinical manifestation, is resembling other clinical manifestation of respiratory issue in pediatric. And due to a small number of patients, diagnosis and management, it is mainly gated from adults' data, and duration of the anticoagulation therapy, role of the thrombolytic and catheter-based therapy, still it is under studies on pediatric. In most case scenarios, it is silent and under-detected, which is if we have less 40% of the pulmonary blood flow. The main presentation I can describe it is refractory hypercapnia in hyperventilation situation. We'll talk to that later on, as well as refractory hypoxemia with higher oxygen support that also could raise the suspicion and sign of the right heart strain in severe form, which is if the blood flow exceeding the 50%. Mortality is far high in intubated patients and who reach cardiopulmonary resuscitation than who detected before and being able to be diagnosed and through the CT. Incident in pediatric population based on the registry of embolism in US, it is around 0.5 per 10,000 per year. In that in hospital setting. However, in retrospective study of 3,600 autopsy, they reported 3.7 with 133 incident of the massive PE. And with related mortality, 31% of them. So most of these cases is detected on the autopsies. And only 15%, which is 20 among the clinical suspected PE, had underwent pulmonary CT and diagnosed to have PE before. So most of the mortality, most of the detection is unfortunately is being missed. And mortality related to the time detection, mechanical ventilation, and TPAs. So an adult data describing overall mortality of the pulmonary embolism, they get around 280 overall, and the other thing who had cardiac arrests around 22%, 22 patients. Only one patient survived, the other passed away. Other major consideration, the patient who required mechanical ventilation, around 50 patients, 40 patients of them died when they reached the level of the mechanical ventilation. The good thing, using of the systemic thrombolysis, it's been showed decreasing the mortality about 30% of these cases. However, now on intermediate risk group, using the catheter-based therapy will be associated with higher rate of successful as well as much less mortality. So we'll go for the major risk factor on which patients. Little bit different in comparison to adults. So adults, they are 31% of them, they have idiopathic reason of the thrombosis. In pediatric, we most likely 98% they have already risk group. Central venous catheter will be one of the associated with chance of the thrombosis, as well as found on 67% who have VTE on trauma patients. The other thing, congenital heart disease. Nowadays, congenital heart disease surgery become more popular and the surgery being increased. However, the risk of thrombosis is associated highly with those group, as well as the successful malignancy therapy. Nowadays, we are seeing also malignancy patients had a risk of the thrombosis later on. So basically, based on the first triad of the thrombosis, first damage of the endothelium could be a reason for creating a thrombus, which is, I can say, central venous catheter. One of the things could describe the thrombosis, as well as inflammation. Also, the systemic infection can affect the endothelium. Other thing, change of the laminar flow by compression by congenital heart disease also have association, and the other cause of the increasing stasis like thrombophilia, any thrombocasia causes like factor V Leiden, deficiency of anticoagulation protein C, protein S, antithrombin 3, like in patients with nephrotic syndrome, they're prone to have thrombosis compared to the others. A nice data study done by Susan Williams in sick kids. She described the most common risk factor in pediatric age group over 8 years experience. She found most of them, they have already multiple risk factor, but she described the immobility, one of the most common, and the other second one, which is introduced by medical team, is the central venous line. Recent surgery, and especially prolonged surgery exceeding 2 hours associated with pulmonary embolism and congenital heart disease as well, and other things, malignancy and thromboembolic abnormalities and previous DVT. So this is the most common risk factor in pediatric age group. So let us to go for the pathophysiology to understand how to detect and when you will be worried, you probably understanding the surgical consideration is very important. Emboli obstructing 50% of the pulmonary circulation, less than 50% will be associated with silent, probably will not be detected and will not be associated with major cardiopulmonary disease. And they found a segmental pulmonary artery affected around 50% of the cases, where the main and central artery affected only in 6% of the cases. That's why, like surgical embolectomy, sometimes they have multiple revision because the proximal relief of the proximal did not necessarily relieve the distal thrombosis. 3 major features. We need to focus on the physiology, which is RV straining. The other is refractory hypoxemia, which is not responding to higher oxygenation consideration, with 2 physiology behind it, the space ratio, as well as shunting in case we have a PDA. And the other scenario, if we have hypercapnia in a hyperventilation situation. Speaking about RV strain, embolus on the pulmonary artery will be associated with increased resistance and increasing the afterload, leading to RV dilatation, increased left ventricle end diastolic pressure, then associated with heart failure. Then after that, the patient will have dilatation of RA, and in case the patient have a PFO, he will be shunted right to left and could be associated with cyanosis. In such situation, in case the RV dilated, that will be affecting the LV filling and LV preload, and associated with decreased stroke volume, and with that associated with decreased coronary perfusion, especially on hypotension of the patient with pulmonary embolism. That's why hypotension should be avoided and treated aggressively to maintain coronary perfusion. So basically, they have high PVR, right ventricle dilatation, and wall stress, which is leading to right coronary ischemia. Also, they have a poor LV filling, leading to ventricular interdependent situation, leading to decreased stroke volume, hypotension, and left coronary ischemia. So basically, tachycardia is one of the major features of the straining. Hypotension is risk factor of the coronary perfusion, and low SVR will be contributed more and more ischemia. We'll go to the lung and perfusion. So basically, we'll speak about the VQ matching. Normally we have equivalent matching between ventilation and perfusion. There is a situation the ventilation will be higher than the perfusion, where in situation in case we have COPD or asthmatic patients. And usually those patients will be oxygenated to some extent unless they reach a level they did not have no perfusion, and the other segment of the lung will be have a good oxygenation, so they will compensate by the tachypnea to be oxygenated. On the other way, in case we have an area have no gas exchange, like in atelectasis and intrapulmonary shunt, or a right to left shunt, which is intracardiac, this is also associated with cyanosis. To quantify this dead space, which is the area of area of air did not meet to the blood. Usually we quantify it through dead space volume over the tidal volume. However, this quantity cannot be detected easily through the monitor. We are utilizing a surrogate for that by using tidal CO2. So we are getting the arterial CO2 minus the tidal CO2 over the arterial CO2. For that, we can detect the physiological dead space, which is coming from anatomical through the nose and upper airway, which is usually roughly around 10% to 15%. In case dead space increase more than 33%, associated with symptoms with tachypnea and respiratory distress to be maintained. 40% will be associated with hypoxia. 50% will be associated with profound hypoxia that will not be responding to be oxygenation, as well as associated with hypercapnia, with hyperventilation situation. Speaking about the shunts, usually the hypoxia happening on pulmonary embolism will be happening in case dead space is increased more than 50, as well as the shunting through the PFO, and in case the shunt exceeding the 50% of the cardiac outputs. Other thing which could be thinking about, which is excluding the embolism in case we have abnormal X-ray by infiltration that's increasing the diffusion, that could give a picture of the dead space ratio, increase this dead space ratio. However, will give could be a wrong impression to have a dead space, where usually on patients who have ARDS usually have same dead space issue. So that's we will be able to exclude. However, we cannot guarantee if there is pulmonary embolism through tidal CO2. So going to refractory hypoxemia, which is not responding to concentration. First, we need to exclude intrapulmonary shunting, either lung collapse or diffusion, which is that can be detected through the X-ray and by either lung collapse or infiltration on the lung. That will be much worse in case the patient have BFO, so which lead to have right to left shunt and beside the major dead space issue. Hypercapnia in hyperventilation situation. Like most of the intensivists, when they are facing this situation, it is really hard to deal with, because the logic cannot help on such situation. Patient have normal, probably high minute ventilation. His RR is very high. His his tidal volume is good. He's moving air very well. However, his CO2 is still high. Been described before on literature on 1984. So hypercapnia complicating massive pulmonary embolism, irreversible hypercapnia secondary to pulmonary embolism, So this picture is being addressed, and the physiology being explaining this, especially with understanding the dead space ratio, and on such situation, the best way to compensate the CO2 is actually the person spontaneous breath. So high minute ventilation, they will have high RR, they have excellent tidal volume with a good chest rise, but the patient's arterial blood gas will be associated with high CO2. And to detect this problem, you will be able to connect the patient through nasally or through end-tidal CO2 to see discrepancy. So usually you will able to see much low end-tidal CO2. In case end-tidal CO2 exceeding 40, it is less likely to have pulmonary embolism. However, in most scenario, massive pulmonary embolism, it's around 20 to 30 situation. So clinical presentation. Pediatric pulmonary embolism often silent, and a retrospective study on children who eventually diagnosed with pulmonary embolism, they found actually the patient have symptoms of tachypnea and sign of that tachycardia before, but is being missed. And this is describing why tachypnea is the best indicator for early sign. But we have to rule out the other cause of the respiratory manifestation. Chest pain, hemoptysis, less in pediatric population compared to the adults. However, young adult pediatric age group, they have more description of the hemoptysis as well as chest pain. For intermediate and high risk group, so basically those group, there will be much obvious sign, which is usually in case we have more than 50% of the blood flow going to the lung is being blocked. So in such scenario, usually we are seeing a tachycardia. And in adults, there's a mortality predicted value when the tachycardia is exceeding 100. As well as on pediatric, we found doubling the heart rate will be associated also with increased suspicion. Sign of the right side heart failure, edema, hepatomegaly, and GVB also, this is one of the findings can be detected on pediatric. Desaturation, and in case it's happening without lung disease before, it will be associated with high severity at this stage. However, some of the patients who have respiratory manifestation or chest infection or lung disease before, they can be had pulmonary embolism, which is being masked by the initial disease. Other thing, they will be associated with respiratory distress, and this is the sign of the compensation. Classification of the acute pediatric pulmonary embolism, it's actually taken from adult experience based on the recent literature review of the pulmonary embolism. They can describe it to high risk group, intermediate risk group, as well as low risk group. So speaking about high risk group or an adult, we name it massive pulmonary embolism, defined when the pulmonary embolism causing cardiopulmonary arrest or sustained hypotension for at least more than 15 minutes and or requiring vasoactive support to be maintained. So this is considered high risk group. Intermediate group who will be defined to have BE without hypotension or compensated shock, but they have evidence of the right heart, right ventricle strain by imaging, and myocardial necrosis by elevated cardiac troponin or both. Low risk group defined as acute PE not meeting the criteria of the high risk or intermediate risk. So diagnosis. So speaking about diagnosis, there is area could suggest and there is area could confirm. Confirming diagnosis, nowadays with improving the imaging, it is helped to improve also the detection. SPECT-CT become much more safe, and they're able to also see the distal perfusion with lower exposure for the contrast as well as radiation, which is improved. The detection of the perfusion abnormality has been found to increase sensitivity and specificity in lung, which is around 100% sensitivity and 98% specificity. Gold standard is the pulmonary angio with or without cardiac catheterization. However, this is little bit show risk on adults, especially on massive PE who's unstable, but have significant detection with properly intervention later with the patient who have intermediate risk. Diagnosis, it is diagnostic test good on patients who have congenital heart disease as well as post-operative PE, and may necessarily to diagnose PE in small children or if we have distal vessels PE. It is diagnostic test also for aortopulmonary shunt thrombosis. MRI, one of the tools, can diagnose with around 98% of the sensitivity, however, 92% specificity. The problem with the MRI, distal thrombosis could be missed because of the MRI. PQ nowadays did not. It was a good, excellent tool in the past, but nowadays being replaced by the CT. Then we'll go to the echo, which is a tool. It could be available in everywhere and can come to the patient bedside. In fact, echo, the aim of the echo is not to confirm, rather than to assess the severity and to raise the suspicion in case we have right heart strain. Generally, right heart strain will be very obvious on submassive as well as massive group, and the feature of that it is still associated with same as pulmonary hypertension, with flattening intraventricular septum, paradoxical septal motion, and quantity depressed RV function. McConnell sign, which is hypokinesia of RV free wall, one of the characteristic feature of the RV strain being utilized in adults, which is in pediatric probably still that role is not well defined nowadays, and in the low risk group, criteria of diagnosis on the RV strain still not standardized on adults, and in pediatric still also the standardization is not finalized. But probably we have low sensitivity and specificity, especially on peripheral PE and in single ventricle patients. We'll go to the ECG. Changes from core pulmonal or subsequent right heart strain, that the main focus we can detect it of the ECG, which is right axis deviation, right bundle branch, sinus tachycardia, ST segment abnormalities, and T-wave abnormalities. In adults, classical S1Q3 T3 pattern is not reliable and not validated on pediatric age group. One of the major tools we've been utilizing nowadays is to help to exclude is the end-tidal CO2. Basically, we are detecting the wasted CO2 which has come from the lung, which is that the area of the volume did not contribute on gas exchange. Usually that one associated with lower CO2 and compared to the systemic CO2. Roughly, if we have dead space around 15%, this is considered normal. And in adult data, less than 20% of entitled CO2 that exclude permeable embolism on 100% on 100% value, and above 40 raise the suspicion of the permeable embolism. D-dimer to exclude and to suspect. Normal value on adult data exclude 100% of the PE. However, in pediatric exclude only 86. Still, we are seeing PE patients with normal D-dimer. But still one of the tool of the suspicion. Speaking about now is the management. To start, we'll start with the allocation. Allocated those group with permeable embolism, it's based on the clinical manifestation. So low risk group can be safely assessed in the ward in standard monitor situation, and the mortality risk is around 1%. Intermediate and high risk group need ICU monitoring area. Invasive arterial monitoring recommended on high risk group to assess the blood pressure, as well as to maintain a targeted management of the hemodynamic situation, beside the entitled CO2 to assess the severity of the permeable embolism. Consideration for permeable embolism in ICU setting. First, we will focus on pulmonary vascular resistance. Our aim is to decrease the pulmonary vascular resistance as much as possible. The first consideration, we have to provide higher oxygenation on such a group. So 100% FiO2 through non-rebreather face mask, it will be a great. And we still would like to avoid positive pressure ventilation to maintain function residual capacity, and we'll come to that later on. Nitric oxide, no data on pediatric showed the utilization of nitric oxide of permeable embolism. However, theoretically, it will help to decrease the PVR. Normalization of the pH as well as arterial CO2 is very vital to decrease the PVR. However, in severe form, this could be difficult to maintain the CO2. So usually we are working to correct the pH on such scenario. Maintaining functional residual capacity, which is not be easy to be maintained unless with spontaneous breathing. So avoidance of the intubation should be one of the things in case the suspicion of the permeable embolism is there. However, an ordinary support, if we have hypoxemia with FiO2 not responding to 100% FiO2, the positive pressure ventilation is the under pulse guidelines to be supporting such patient, because we are dealing with hypoxic respiratory failure. However, that will be not necessarily helping patient with permeable embolism. So diagnosis is very vital to prevent the deterioration and utilization of positive pressure ventilation of those patients. In case patient being intubated, so we'll go for maintaining a strategy to decrease PVR by keeping the patient spontaneously breathe, utilizing lower beat, utilizing lower tidal volume, and allow the patient to wash the CO2 as much as possible. In case the patient is spontaneously breathing with control rate, usually targeting decreasing I time. General consideration regarding the systemic vascular resistance, the aim of that is to decrease the risk of the cranial perfusion. We are avoiding the sedation, we are normalizing the pH. Fluid, it needs to be deal with the justice, because more fluid will be associated with RV dilatation. Use vasoactive agent that maintain good diastolic blood pressure to maintain cranial perfusion. Inotrope agents could help, like norepinephrine, with less extent epinephrine on such situation. Vasopressin will be associated in adult data with refractory hypotension not responding to catecholamine, associated with good role to maintain the blood pressure, especially catecholamine. Sometimes of the acidosis happening of the patient with pulmonary embolism, it will be not responding very well. Besides, the catecholamine risk of the increasing PVR still there, which is not for the vasopressin rules. So then this is in general the major supports in the beginning. Then after that, we'll look for the perfusion support, so treating the cause. The main outlines of the perfusion, usually thrombosis, surgical embolectomy, and catheter-based therapy. A published treatment algorithm for children still they're recommending thrombolysis as high risk, and also they utilize the surgical embolectomy in certain case and catheter-based therapy, and we're going to go to talk about this. Thrombolysis was associated with decreasing overall mortality on adult population as well as on pediatric population. However, risk of the bleeding associated on around 20 to 30% of this group, with discrepancy of the dosing utilized on thrombolysis because there is no clear guidelines about utilization. And still, it is the first line in high risk group. Catheter-directed thrombolysis and surgical embolectomy in adults will be reported based on the meta-analysis of 35 cases of 30 days mortality estimated around 8% only, with a bleeding tendency of 6.1 cases, and this is in general for high risk group. In comparison to systemic as well as surgical embolectomy, catheter based therapy associated with higher success as well as lower risk of the complication. On VA ECMO with suspected or confirmed high risk PE who remain hemodynamically stable is so recommended, and also for the patient who had experienced cardiac arrest. That on the area where we have ECMO support. For that reason, in case we have presence of the ECMO, it is superior to stabilize the patient before systemic anticoagulation, which is can be associated with higher chance of the bleeding during ECMO cannulation. And catheter-based thrombolysis could be utilized after stabilization through the ECMO. During thrombolysis, usually we are targeting platelets above 100 and fibrinogen also above 0.1. In pediatric, we have a range from 21 to 28 bleeding tendency. However, they did not describe the extent of that bleed on some reports. On sick kid groups, they have around 10% major bleeding with thrombolysis. Other thing, the systemic will be associated much more than chance of the bleed than catheter-based thrombolysis. Special circumstances in case we have a patient who have cardiac arrest before confirming pulmonary embolism. Still, the standard CPR should be administered according to pulse regulation, and ECMO ability for suspected cases should be utilized. In case there is no ECMO, intra-arrest thrombolysis may be considered. However, for intermediate risk group, which is adult guideline recommended against routine use of thrombolysis based on the meta-analysis. So they have cohorting around 970 cases associated with 97% of the success with zero mortality. Only a small case series done on pediatric of 35 case, which is reported a favorable outcome for the catheter-based therapy in intermediate risk. Future focus, we would like to raise the suspicion of pulmonary embolism in pediatric who have high-risk group like congenital heart disease, malignancy patients, neonatal, as well as like young adult group, VTA prophylaxis to be to high-risk pediatric population should be placed on the recommendation, same as adult, because the physiology is one, and catheter-based thrombolysis in intermediate risk group should be considered and under discussion, as well as creating a guidelines for such a group. Thank you so much, and willing to have a question, Dr. Umar and the group. I hope being on the time.
Shukran, Dr. Ali. Thank you very much for this nice comprehensive review, and surely we will have questions. The audience, they can raise their hand if they want it. If they want to write, they can write it in the chat. But until they prepare themselves, I have few questions in my mind. When you are reviewing the classifications, the classification doesn't mention anything in the mass of the size of the masses or anything. This is the reality.
Yes, basically, I can say the classification, they work basically on clinical manifestation. They did not think about like the size of the mass or presence of the thrombosis per se, which is also could you create high risk. That's the thing on intermediate group. They are recommending to have a committee meeting regarding such cases because presence of the clot inside the ventricle while the patient on compensation stage and sign of the right heart strain is still be associated higher like risk of deterioration compared to the one who have mass. So in pediatrics still we didn't reach a very directed algorithm compared to the adults with that regard, Dr. Umar.
Yes, thank you. I think this is important because people sometimes they're just reacting because they see the size of the things and they just want to do a lot of things. The other thing which is I'm noticed here is it's a clinical decisions. It's a symptom of the patient, everything. It's not going with a lot of image. If the image showing you like one of the arteries fully blocked you and the patient is okay, so you will classify him as low risk, isn't it?
Yes, low risk.
Low risk.
Exactly.
And if he has only small obstruction here and there, you will put, and he's very symptomatic and hypertensive, you will put him in high risk.
Exactly. Honestly, Dr. Umar, we will think regard pre-embolism, really monitoring area is really have a vitals with that, and also compare catheter-based therapy in comparison to thrombolysis as well as anticoagulation management in general on intermediate risk group. They found actually the length of the stay of this group is higher than catheter-based thrombolysis. That one thing, it's been obvious on adult data. However, still low risk group, they could compensate while the more than 50% of the blood flow is maintaining. That means the patient still will compensate by himself from the cardiac output, as well as oxygenation, as well as ventilation by washing the CO2.
I see. Also, Dr. Ali, because of some of the people he's around is also our cardiologists. The easy thing is in the cardiology is just you are not pushing to see where is there is embolism here or there. You are trying just to see the RV function, strain, and this thing, and dysfunction, and the others. If you can see the embolism or not, this is not an issue, isn't it?
Exactly. Yes, this is the thing. We'll probably going to the direction of the management based on finding of the imaging, but not going with clinical manifestation, probably associated with complication. This is the thing. People try to avoid this through the classification, and this is also an adult population group. So still an adult population low risk group is still recommending anticoagulation, regular anticoagulation in comparison to catheter-based thrombolysis.
Okay, Dr. Ali. So from your presentation, this case is a pulmonary embolism is a clinical diagnosis. True. In patient who deteriorating and you cannot explain it, because really we every one of us maybe he has a cases which is suddenly died and you cannot explain what happened, or suddenly deteriorating is not a sepsis, blood culture doesn't come sepsis, no fever, nothing, and just he deteriorating, and over a few hours he's dead. Exactly. And really you can just keep yourself why he's doing that and what happened, and is it, and you know that always we are trying to just get an explanation, which is it error, medication error or something, or that which is cannot go. I have here also a comment from one of our colleagues here. He's the COVID. You know, in the COVID time, the adult population, the pulmonary embolism was higher than usual. In children, do you notice anything in the children?
Yes. In general, in children, the problem is the suspicion will be high compared to the adults. We had one case, we raised the suspicion in the beginning, but it is confirmed ARDS situation with significant dead space ratio was high on that patient, and CT was done to rule out embolism and being rolled out. Yes, we faced one patient who had clear lung. He is a nephrotic patient, and he had sudden deterioration of the hypoxia as well as hypotension. And the team decided to go by ordinary support by giving him a high concentration of the oxygen, and the patient was required to be intubated at that stage. Echo was done bedside and was showing significant right heart strain of that patient. With definitely he had been COVID positive, but the lung did not show the picture of the ARDS. So the suspicion of the pulmonary embolism was highly suspected on that patient, and he had significant dead space ratio. However, the patient after the intubation, he manifested by cardiac arrest and refractory hypoxemia, which is not being explained by higher FiO2 support the patient have, as well as refractory hypercapnia. I agree with you, Dr. Omar. These cases, once being detected, he will be detected in late stage without raising the suspicion utilizing point of care echo, or as well as the risk factor anticipation. It could go on the other way, because mechanical ventilation per se, it will be associated with harmful support for patients with pulmonary embolism.
Before we conclude our meeting, but from all the presentation, what I learned today is that we are talking about medical decisions, clinical cases, medical decision, medical treatment. The last thing you have to call is the interventionist and the surgeon, because you will start your medical treatment. So you don't need to be in a cardiac center or high advanced cardiac center or anything. You can save a patient, because from the data of the thromboembolism and surgery is not really is not showing more difference in the result from the thromboembolism. Is I'm right?
Last few seconds, probably have the issue of the connection. Is my voice back?
Yes, Ali. I can hear you.
Yes, I can probably represent the answer. Like pulmonary embolism, whether need a utilization of the cardiology and the cardiac surgery as major role of the treatment. I can say, Dr. Omar, yes, on intermediate submassive group. Especially adult data have significant result of utilizing catheter-based therapy, which is associated with high successful rate, lower mortality rate, and lower bleeding tendency. On pediatric, I guess like we have lack of the data, and mainly in case series, which is also associated with higher successful rate with lower bleeding tendency, as on second group being described. No, definitely, actually, especially on submassive group, Dr. Omar, I can say is very vital. And in the group of the massive who have a cardiac arrest or refractory hypotension to the medical therapy, cardiac surgeon and ECMO support is very vital to be utilized.
That's great. I think we are near to finish. But any one of you have any questions? You can unmute and or comment, please. Can unmute and talk. If you are happy and everybody understanding this nice presentation, we'll thank Dr. Ali for his joining us, and he agreeing to join us for this monthly activity from our Saudi Society of Pediatric Cardiology and Congenital Heart Diseases. And we hope to see you every time. And thank you, Dr. Ali.
Appreciate it. Thank you to have me today.
Thank you. Assalamu alaikum wa rahmatullahi wa barakatuh. Fi aman Allah.